friend, Dr. Jalal, for so many years. You know, I have seen Jalal 20 years ago as one of the most handsome neurosurgeons of the world. Unfortunately or fortunately or whatever, Syria, I wish that peace prevails in the whole world. Peace prevails in Israel and in Middle East and in Palestine. And we are for peace.
Thank you very much.
Sometimes we imagine, Jalal, that we try to save patients who have tumors, who have disease. We spend our whole life in treating patients, diseased patients, and here what we see is killing of healthy people, young people, children. I only hope and wish that sense prevails in the world and we all get peaceful world, Jalal. And
We hope so. Thank you very much.
peace to you in Syria. And let us go on to our topic. John, you want to say anything about peace in the world?
I prefer to stay away from politics if possible. In this form, okay?
Yes, of course. So I will go on to pituitary tumors. Pituitary tumor is our life of neurosurgeons, and we all like to do pituitary tumor surgery. And pituitary tumor surgery is one of the most rewarding neurosurgical exercise. We give vision, we give life, we give various things if we do a good pituitary tumor surgery. Here, what I'm going to show is anatomy of tumors. I'm going to show you several images of pituitary tumor, and then I will try to relate how these tumors spread and how we should attack these tumors surgically. So pituitary gland is located in a very special location. This location is neither intracranial nor extracranial. It is a loaded location. It is located medial to the cavernous sinus, underneath the chiasma, medial to the carotid artery, located in the vicinity of the nasopharynx. As we know, nasopharynx is the air conditioner of the body. Any kind of air which comes, whether it is hot or cold, the way it circulates in the turbinate, it becomes normal temperature. And this gives information to the cavernous sinus, to the sella, to the pituitary gland, and so on and so forth. So this location is peculiar, all right, but very, very important and critical for the function and for our surgery, This is the sella turcica located. This is the large hole in the diaphragm celli. This is the pituitary stalk and carotid artery. So we have written a very beautiful article on anatomy of the pituitary tumors. And I have written several articles on pituitary tumors over the last 30 years of my pituitary life. And some articles are on giant tumors and some articles are on controversies and challenge of giant pituitary tumors. This is in World Neurosurgery and the concepts based on pituitary tumor surgery. We, of course, know Cushing disease, that we do a good operation and we cure the person. We do a half-hearted operation. This patient is dead in 6 months. You give radiation, you do anything, the results may not be all that gratifying. So surgery in Cushing disease, surgery in acromegaly, surgery in various forms of functioning tumors and non-functioning tumors is very, very highly important. So Cushing disease, there is no question that it has to be removed as a nodule. Regarding non-functioning tumors, they become large or giant. And you see, I'm showing you some giant pituitary tumors of various kinds. They have, if you see carefully this tumor, there are multiple cysts. All cysts have fluid levels. This is a necrotic tumor. They can grow very large in size. Even if you see this tumor, if you see this cyst, patient lying supine, there are fluid levels in every cyst. Every cyst has a fluid level. This has special implications in the ultimate outcome of these tumors. So this is another huge tumor. This is another beautiful one, another fantastic one, another magical one, another great one. So these tumors can achieve very huge size. They can go in the sphenoid sinus, in the paranasal sinuses. So this burden of the magnitude of size is important. These tumors, if we understand these tumors, they are different. If we do not understand these tumors, they are like lions. But if we understand these tumors, they can be taken out like flowers. So in India, somehow or the other, I don't know whether in other countries, we have the power of size, we have the power of complexity, and we have the power of numbers. And this has been my personal power over several years working in a public institution. So even when the tumors become large or massive, they have a method in that madness. And we have to understand this method in madness. And this method in madness, I'm going to show to you. Most important is, and one which we describe for the first time in the literature is, even when the tumor becomes large and grows superiorly, the diaphragm celli is elevated on the dome of the tumor. So this was never described earlier. Earlier description was the tumor comes out of the diaphragm celli and this part of the tumor is subarachnoid in location. You can imagine if it is in subarachnoid location, it is impossible to remove these tumors from the nose. So 25 years ago, all these tumors were removed from a transcranial route. You see the diaphragm celli dura is elevated on the dome of the tumor. And there is no question in my mind, this concept that the diaphragm is elevated, you remove the tumor, the diaphragm comes into picture, has completely revolutionized pituitary tumor surgery, and I take the credit of that revolution. So even when the tumor goes like this, you see it looks like a haphazard kind of extension, but it is under the diaphragm, and this diaphragm protects the tumor or keeps the whole tumor in a confined territory. So this tumor is under the diaphragm. So I'm going to show you several images. So when this tumor grows up, it is not, this supracellular part is not in the subarachnoid location. It is under the diaphragm celli. It is displacing the vessel. It is not in the subarachnoid space or not encasing any arteries of the circle of Willis. You see the diaphragm is elevated. The whole tumor is interdural in location within the confines of dura. You see this tumor, it is under the dura. And that understanding is so important. If it is going in front, if it is having this kind of image, but the most critical issue is there is a diaphragm celli which is around the tumor. So these tumors which arise or which probably arise in the cella, grow in the supracellular area, are under the diaphragm celli. And this location, understanding of this location is very important, under the diaphragm, under the diaphragm. So even when you see this kind of lobulation, it is under a well-defined plane of dissection, and that dissection plane is determined by diaphragm celli dura. Even when there is a small nubbin like this nubbin does not mean that it has transgressed the dura, it is within the dura. If you see a bigger nubbin like this, it does not mean that it is outside the dura. Believe me, if you do not have this concept, you just cannot remove this tumor. If you come transcranial with the concept that it is subarachnoid and you have to dissect from the vessels, then you cannot do it. If you have a concept that a well-defined plane of dura, you can relatively easily remove these tumors from the nose. You see, this is going into the brainstem, all right, but there is dura, there is dura. So this concept has, in my estimation, completely revolutionized pituitary tumor surgery. When there is a subfrontal extension, the whole world was doing transcranial operation 20 years ago or 25 years ago. But this concept that there is dura, you can remove this tumor from the nose in 15 minutes. This tumor has become large, but there is dura around the whole of the tumor. There is nubbin here, but this nubbin is under the dura. There is a big extension, maybe go beyond the convexity, beyond the corpus callosum, but it is entirely covered by dura. So dura matter, dura mother, and this mother tumor respects, and you have to respect during surgery. Even the sphenoid part of the tumor has thin layer of dura and a thin layer of bone. So these tumors are of different type. They are relatively benign pituitary tumors. All giant pituitary tumors are benign, but amongst those tumors in the sella and diaphragm are relatively or quite significantly benign pituitary adenomas. Tumors which go in the sphenoid sinus and in the paracellal area are relatively more aggressive than those which do not go in the sphenoid sinus. You see here completely within the dura. This nubbin is also within the dura. They displace the blood vessels. Now what tumor I call grade 2 is when the tumor encases the artery of circle of cavernous sinus and enter into the confines of cavernous sinus. Cavernous sinus, the lateral wall is intact. So entire tumor is within the dura. Lateral wall is intact. Tumor involves the cavernous sinus. These are grade 2 tumors. So you see here, it is involving the cavernous sinus. Diaphragm is intact, cavernous sinus, lateral wall is intact. It is within the cavernous, it is within the dura. It can involve both cavernous sinuses. It can involve sphenoid sinus. So whether it has gone outside the dura or not, that you have to understand. If it goes inside the sphenoid sinus, it is more aggressive. It can go primarily into the cavernous sinus, but the dura remains intact. I call them grade 2 tumor. Medial compartment of cavernous sinus, medial dural wall of cavernous sinus is a relatively misunderstood structure, and this is what we had written in this article. Here, the tumor involves both cavernous sinus, lateral wall is intact, the roof of cavernous sinus is intact. Lateral wall is intact, diaphragm celli is intact. So this is a confined. It has a method in the madness. It is not a haphazard or irregular kind of extension. It has a very defined kind of extension. Even when they become massive like this, you have to understand how the dura will be and how it will be displaced if you want to remove them radically. Here, in this case, the diaphragm is elevated quite dramatically. The lateral wall is elevated quite dramatically, but not transgressed. And this anatomical understanding is so critical. Now I want to show you the third category, grade 3. Here, in this case, it has gone, the tumor has gone in the cavernous sinus. It has elevated the roof, dural roof of the cavernous sinus. It has elevated the diaphragm celli. So still it remains within the dura. Here it has elevated the dural roof of the cavernous sinus, diaphragm, lateral wall. It is a confined. So large pituitary tumors, diaphragm, roof of cavernous sinus. You see, beautifully seen diaphragm and elevation of the dural roof of cavernous sinus. Beautifully seen here, elevation of dural roof of the cavernous sinus, elevation of the diaphragm cell. You see, it looks like a haphazard. Nobody had ever discussed this entity. Elevation of roof of cavernous sinus was never discussed earlier in the literature. Elevation of diaphragm celli was never discussed in the literature. Preservation of lateral wall of cavernous sinus was never discussed in the literature. You see how the dural roof of the cavernous sinus is elevated. You see, this looks like a haphazard kind of displacements, but here there is dural roof, here there is diaphragm, dura. You see this tumor, beautiful elevation of dura, beautiful elevation of dura, beautiful diaphragm celli elevation. You see this tumor looks like a very haphazard kind of tumor, but there is a method in this madness. This kind of nubbin here you are seeing, this is elevation of a dural roof of cavernous sinus. This nubbin that you are seeing is elevation of dural roof of cavernous sinus. This is a beautiful tumor. Elevation of dura of roof, elevation of diaphragm, elevation of dural roof of cavernous sinus. You see this complex kind of situation? This is elevation of cavernous sinus roof, elevation of diaphragm, elevation of dural roof of cavernous sinus. This looks like a haphazard kind of extension of tumor, but there is a method in this madness. There is dural roof of cavernous sinus, and there is diaphragm which is preserved. This tumor, if you see, there is elevation of dural roof of cavernous sinus. the chiasma is involved by this part of the tumor. Diaphragm cell, it is not involving the chiasma. If you have to get the vision back, you have to remove this part of the tumor. Beautiful tumor, I call it a duck tumor. The head of the duck is the roof of cavernous sinus. The body of the duck is under the diaphragm. This is another strange kind of animal. I have not yet named it, but you see elevation of dura, elevation of roof of cavernous sinus. The diaphragm is not so much involved here. This elevation is the elevation of the roof of cavernous sinus. Now, grade 4 tumors, I call them, which transgress the roof of cavernous sinus, encase the arteries of circle of Willis. They are not respecting the mother dura. Those who do not respect the mother dura, I call it malignant tumors or malignant children. And these are malignant. How you have to remove these tumors which encase the arteries of the circle of Willis is a different chapter in neurosurgery. So these tumors, beautiful tumors, and this is my this tumor involved the clivus, and this was a smallish paper on the subject. Sometimes recurrent tumors are different. So this tumor was a recurrent tumor, and how to remove this tumor, whether you want to remove endoscope or just want to put a finger in the nose, you can do that. But they are having some kind of haphazard when there is human intervention in these tumors. So this is my grading scale. Grade 1 is when the diaphragm is elevated and diaphragm is having nubbins. Grade 2 is when it involves cavernous sinus. Grade 3 is when it elevates the roof of cavernous sinus. Grade 4 is when it encases the arteries of circle of Willis. And this was the publication. And here I have put this publication because my fellow from Egypt, and Samay will be happy to see this publication from my Egyptian fellow. So understanding this anatomy is important. Whether you use endoscope or microscope, that is not much of an issue. And I will show you some cases which are, as Jalal said, 20 years or 30 years old. This must have been operated 25 years ago. Just remove the anterior wall of the cella. Learn the art of breaking the tumor, and the whole diaphragm will come into picture in 15 minutes or 10 minutes. Beautiful visual outcome. Uterus is the strongest muscle of the body, more than bicep muscle or tricep muscle or gluteus muscle. This muscle is stronger than the bum muscle, and this muscle has a power to push the baby out. And this muscle has the power, this dura has the power to push the tumor out. There is no need for cesarean section in pituitary tumors. You have to come through the nasal cavity, break the anterior wall, break into the tumor, learn the art of normal vaginal delivery rather than resorting to cesarean section from these tumors. Whether you use proctoscope or endoscope for vaginal delivery or whether the delivery will be spontaneous, you have to decide by yourself. But of course, I use microscope for these tumors. And this, whether they become the baby, there is a twin baby or triple baby, the baby is baby, you remove from the anterior wall and you learn the art of delivering the tumor. Breaking the tumor, demolishing the tumor. You see this nubbin does not mean it is outside the dura. Anterior wall, I am not sure how much time I removed this tumor. If I have removed in more than 15 minutes, that must be a bad day for me for removal of this tumor. Even this cellar extension has a method, complete interdural location. So these tumors, like trigeminal neurinomas, are interdural in location. This looks like haphazard, but this is post-op, this is complete dura. If you do not have this concept, you cannot remove this tumor. If you do not have this concept that this whole thing is under the dura, if you do not know how to demolish pituitary tumors, I have a feeling that it is a difficult time in neurosurgery for you, because these tumors are the most fantastic to demolish. This is a pregnant tumor. You see the belly is quite big. Break into the belly and the head will bow down in front of you in no time. This is another pregnant tumor. Break into the tumor, the head will bow down in no time. And this controversy of endoscope and proctoscope are very dangerous controversy. most important is not technique, not technology, it is philosophy. This tumor I removed 25 years ago from the nose. You can imagine my firm concept. Diaphragm is intact, break into the belly of the tumor, and the whole tumor can be demolished from the nose. I did it 25 years ago. This is another 23 years ago. I removed the whole tumor from the nose, and beautiful. The results will be magical if you know how to remove this tumor. The diaphragm will bow down in front of you. And in the evening, if you go and see the patient, he will bow down in front of you, saying that, doctor, you are God and you are great and you are this and that. On the other hand, if you do not, and if you come transcranial, demolish one little vessel, you will not see the patient in the evening of the operation. So if you want to see the patient in the evening and happy patient, you do a beautiful operation. If you do not want to see the patient, that is a different way of handling these tumors. So these are beautiful chapter of neurosurgery. Just break the anterior wall. I use microscope for all these cases, and I do, as I mentioned repeatedly, not more than 25 or 30 minutes will be required for this tumor. You see, beautiful tumor, beautiful outcome. This nubbin is under the dura. This is immediate postoperative. This is cystic necrotic, simplest of all tumors. This is immediate postoperative. This is, see, necrotic, cystic, breakable tumor. Learn the art of breaking the tumor. You see this going a little bit ahead, but don't have to break the whole base of the skull or tuberculum celli or plenum sphenoidal, just anterior wall. Break into the tumor, and very quickly you will remove this tumor. This is also very straightforward tumor. This is also immediate postoperative. This is not within the tumor. This is outside the dome of the tumor. This is another, you see this nubbin? If you do not understand this nubbin is under the dura, you will puncture the perforator and puncture the patient and puncture his tires, and then you will not have the car driving anymore. So this is another tumor. These are dangerous, difficult, beautiful tumor. Danger lies in your hand. Danger lies in your understanding. This is immediate postoperative. This is another postoperative. This is another immediate postoperative. You see this tumor. These are vessels within, these are vascular tumors, and you can see how this tumor has been removed. This tumor I removed in the year 2001 from the nose, just anterior wall. Little bit was left behind. So this tumor recurred in 2007. So now tumors more than 5 centimeter. Even if I have left some tumor behind, 2001, I removed this tumor by just anterior wall resection, removal of this tumor. And in 2008, it recurred. So large tumors more than 6 centimeter, whether I have left behind or not, now I like to give radiation. So this is another tumor post-operative, another beautiful tumor. I could not remove this cranial part, so I did transcranial operation. So indications of transcranial are very far and few in my series. Removal of cavernous sinus part of the tumor is a different chapter. I will discuss on some other occasion how to remove cavernous sinus part of the tumor. But that is also very important to remove this in functioning tumor, at least. Not in non-functioning, you may not remove it. Some residue you can easily leave behind in non-functioning tumor. So this small nubbin of the tumor is under the dura. This nubbin of the tumor is under the dura. In here, I have left some tumor. I could not reach here. Whether you have to remove that residual tumor. Here also, little bit nubbin. I could not remove this in the cavernous sinus. It is a different compartment. But in non-functioning tumors, I have a feeling that you can easily leave some tumor behind. So this is another mega tumor. And this is the tumor I left in both cavernous sinus. You can see many of these tumors were done several years ago, maybe in 25, this is 20 years ago. You see this nubbin under the cavernous sinus. I have left this nubbin behind, and this nubbin has increased. So these grade 3 tumors, now my attitude is a little bit different. I like to give in such residue upfront radiation treatment. So this is another beautiful tumor. These nubbins are under the dura. This is post-op, some cavernous sinus residue. This tumor I did 20 or 25 years ago. You see, I went under the roof of cavernous sinus. This is fat in the sella, and you can do a beautiful resection. This is another tumor. This is fat in the sella and under the roof of cavernous sinus, maybe some tumor left behind. Many of these tumors may need radiation if these tumors, now my attitude towards these tumors is becoming a little bit different when I leave. But in non-functioning tumors, this controversy will remain. I removed this tumor. You see how I went and removed this tumor in the cavernous sinus and all. This another tumor in the cavernous sinus has been removed. So when to remove, how to remove, and what are the techniques and technology in removing cavernous sinus is another chapter which I may like to discuss in next summer's meeting. So these are the tumors you see here. It is going like under the diaphragm. This is from the nose I removed. This rest of the tumor I removed transcranially. Fatal pituitary, Jalal was mentioning, this was first time described by me in 1995. This concept, Jalal, you have to remember this article next time you talk about fatal pituitary post-operative apoplexy. And remember that this first description was by me in 1995. My dear Jalal, so these are the tumor. You see another roof elevation. You see, when you describe something, Jalal, it becomes like your baby. And if somebody names that baby as some other surname, the father becomes a little bit angry. You see, this is your baby and somebody has given some other surname to that baby, you don't feel very happy. Like supracerebellar approach for petroclival meningioma was first described by me. If somebody gives some other name to my baby, I become a little bit angry with that person. So this is another tumor you see under the diaphragm. Now these tumors, which both anterior cerebral arteries are encased, so both circle of Willis is encased. This is a snake of another kind. I am still not very confident as to what technique, how I should do these tumors, but I have come to another conclusion that many of these kind of tumors are hormonally active tumors, and this is after giving prolactin this cabergoline drug. This is after cabergoline, this has gone, and this is another tumor after giving cabergoline, this has gone. So we are now studying the proteomics of these tumors. So in short, summarizing these tumors, what are the danger issues in giant pituitary tumors? When it is very big, when it is higher grade, when the patient is drowsy, and when he comes with altered behavior, and when the patient has hypothalamic dysfunction, these are the danger issues. What are the indications of radiation? Grade 4 tumors, I like to give radiation. Grade 3, when there is a residue in the cavernous sinus under the roof. Grade 1 tumor, when it is more than 5 centimeter, and recurrent tumor of any grade. This is not, this sentence, I think this is wrongly written, but these are my indications. So that is all, my dear friends. Thank you very much, Dr. Samay, and thank you, my dear John. And this is what I have to say about the anatomy of large pituitary tumors. Thank you very much.
Thank you, dear professor, for such amazing as usual. And we all know that you have many babies that you have invented, maybe more than 20 years ago. And always we are, and the OR, your sound in my ears, break the tumor, break the tumor, break the tumor. So your effect is more than you see. The man who works from the spine to the skull base to the tumors. Really amazing. Always, we are very happy to listen to you. Any question from our panelists or friends here?
I would like to have
just a compliment for sir, that sometimes I feel happy that these patients reach to you. Thank you, sir.
Oh, thank you. You have still several years to go. Many will come to you. Don't worry, and you will remove them beautifully. I know it.
Wait and see.
Okay, on to the next.
Excellent presentation, sir.
Yes.
Hello.
Any comments? Yes.
Yeah. Excellent presentation, sir. Excellent presentation. I want to ask one question. In any of your cases, if you are operating transnasal, do you have any chance to operate open in the same setting, or do you prefer to go for transcranial in around 3 to 4 days later? What are your comments?
My comment is that I always try to remove radically from the nose, always. But sometimes, as you know, and as we all know, that it may not be possible to bring the whole tumor down. But, if you leave some tumor behind, you can have a very big disaster and you can have a complication. So you should always make an attempt to remove the tumor radically and remove the tumor as radically as possible from the nose. I have never actually done simultaneously transcranial operation, but as I've shown you in my presentation also, some of these tumors, I have left some tumor behind and I have done them transcranial at a later stage, but that situation should not happen actually. And if it has happened, it is a really bad day for me. But I've never done in the same setting, Dr. Tiwari, as your question, the answer to your question is I have never done same setting.
Thank you. Thank you.
Thank you, Dr. Tiwari.